Hey Life Support listeners, this week we get the chance to talk with Eric Silk of the Clinical Psychopharmacology program at ISU. He tells me what that actually means and what it means for care systems and providers in Idaho and beyond. Thanks so much for listening. Enjoy this episode, and don't forget to like and subscribe wherever you get your podcasts. Okay, so Eric, could you go ahead and introduce yourself?
Yeah, I'm Eric Silk. I am the program director and department chair for clinical psychopharmacology at Idaho State University.
Awesome. Can you also tell us where you are, your pronouns? What do you do when you're not working?
Yeah, well, I live outside of Boise, Idaho. And I relocated here from Wyoming. I came in 2019, so kind of right before the pandemic started, specifically for the job at ISU. So I'm a he, him. And so I've kind of moved around in my life. I'm originally from Michigan. I went to Michigan State University. And then I started grad school in New York City at John Jay College of Criminal Justice. I started in forensic psychology. And then I quickly realized I was in a research position with Columbia and New York State Psychiatric Institute that I needed to continue on. So I started a PhD program in clinical psychology in neuropsychology at Nova Southeastern University in Fort Lauderdale, Florida. So I stayed there for my PhD and then got a visiting professor position there. And I also did a postdoc degree in clinical psychopharmacology there.
Wow. So you're not kidding when you say that you've kind of been all over the place in terms of discipline, geography. But it sounds like you've landed on this psychopharmacology, which sounds like psychopharmacology and criminal justice and forensics all sound like they could be part of a Law and Order SVU episode, but I'm not quite sure that those all belong together. Can you explain the concept of clinical psychopharmacology a little bit more?
This is, I always start by saying this is something sort of old in psychology, but also something new. So clinical psychopharmacology is the use of medications to treat psychological disorders. And I always pause and say, you got to remember that it's also when not to use medication for psychological disorders. So we're psychologists first and foremost, but we do have this advanced training in psychopharmacology. This has been something that has been around since the mid-1980s, is when this idea of a prescribing psychologist is introduced. So it really starts in Hawaii. So that's when the first legislation is put forward for a prescribing psychologist, but it was unsuccessful, and it has been unsuccessful since then. But that said, Hawaii has really been at the heart of the prescribing psychology movement. So it was Senator Daniel Inouye who really championed that with a psychologist named Pat DeLeon. So that was in the mid-'80s, and simultaneously, there's a psychologist with Indian Health Services at the Santa Fe Indian Hospital. In the date's not exactly clear, but it's somewhere around the same time, like mid-1980s. And his name was Floyd Jennings, and they did something really wild with him. So he didn't have training in psychopharmacology, but they needed prescribers so bad that they just gave him prescriptive authority, and he kind of had to learn on the job. So this is pretty wild. In that first year, he treated over 300 folks, and sometimes I make a joke of this. It's not an appropriate joke, but nobody died from inappropriate medication usage. So he continued prescribing for a long time. Then the United States Department of Defense got involved. So Daniel K. Inouye, again, he's advocating for better mental health care for folks in the military. So the Department of Defense puts together this psychopharmacology demonstration project. So what they did is they recruited 10 psychologists, and it's kind of an interesting side note here that they chose psychologists that didn't have training like in biological basis of behavior. They didn't want psychologists that were really already trained in that. They wanted just a regular old psychologist to see if they could train them to safely prescribe medication. 8 started in what is now a clinical psychopharmacology program. Theirs was quite a bit more intense. So about 1,400 hours of training, more like going to medical school. And then they took 2 and put them in a PA program, so physician's assistant program. And it's kind of interesting that after just a short period of time, they pulled the 2 out of the physician's assistant program because it wasn't applicable to what they needed to do. So they were training them in pathophysiology, which is important, but they were missing those critical components related to prescribing and prescribing for psychiatric conditions. So 10 psychologists completed that. So the first psychologist in the military to prescribe is Commander John Sexton. So that's kind of an interesting side note. And then the second one is a very prominent psychologist named Morgan Salmons, who works with the National Register now, who was one of my psychopharmacology professors way back when I did that training. So then at this time, I'd be in graduate school in New York City. In 2002, New Mexico is the first state to have a bill pass and allow for psychologists to have prescriptive authority. At Guam, technically, before that, in 1999. So in 2002 and then 2004, Louisiana. And then later, Illinois in 2014, Iowa 2016, and then Idaho in 2017. I was in Washington, D.C., doing some advocacy work with the American Psychological Association. And I saw my colleagues from Idaho celebrating, jumping up and down, crying. So this would be Kendra Westerhouse and Paige Haviland and Sue Farber, who are all very important psychologists in Idaho. They have done so much to make this happen. And I didn't know what was going on. And they said, well, Governor Otter just signed that bill. And in my head, I remember saying, well, I'm going to be moving to Idaho. And so that's when I started looking at actually making the move, and then later contacted Idaho State University because I'd heard that they were going to start this psychopharmacology training program. And lo and behold, here I am. So kind of a long-winded story, but that's really what got me here, and it kind of some of those roots of prescribing psychology. So been around for a long time, relatively new in Idaho.
No, that is super helpful, just kind of in giving some context. I also feel like next time I go to trivia, when it's history of psychopharmacology, I'll definitely win that round. So that's perfect. Especially when you talk about the geography of those locations that have passed legislation to allow prescribing psychology. We're talking about a lot of rural states and a lot of states that are mental health care provider shortage areas. It makes me think about how you could think about clinical psychopharmacology either as an extension or gap filling resource in healthcare versus a different way of managing behavioral health conditions and mental health. So how do you think about that in your practice? Is it kind of filling a gap with prescribing, or is it kind of a frame shift in the way that we manage medications for mental health conditions?
Ooh, that's a really good question. So let's kind of start at the beginning in that rural areas really do play a critical role in the development of prescribing psychology in the United States, no doubt about it. And we're, in Idaho, the whole state's in a mental health care provider shortage area, and that's notable with psychiatry. So what do you do? And what happens is that you get folks that don't have specialized training prescribing a majority of the medication for psychiatric conditions. So family practice physicians. The psychopharmacology training, they really kind of break it down into different levels of training, from just basic education all the way up to independent prescribing. I kind of find myself in the middle, just personally. So what I do is more consultation. So I work as a regular psychologist, but having that training has really changed the referrals I get and who I'm able to see, complicated medical cases, things like that. It's fundamentally changed me as a psychologist. So I always say, like, you can do this training, never write a prescription in your entire life, and still benefit from it. So at this point, there's been over 2,000 psychologists that have this training, and then just over 200 prescribing psychologists. So it's a small fraction that actually do go on to prescribe. And what that actually looks like, the actual prescribing, is highly dependent on the laws and rules in the particular state. So things like formulary, what patient populations can you see? For example, Illinois has a pretty restrictive formulary. So like prescribing psychologists in Illinois can't prescribe stimulants for ADHD. In Idaho, we have a pretty broad formulary, so psychologists can prescribe for any mental health condition. And in the future, they'll also be able to prescribe medication like Suboxone or buprenorphine for opiate use disorders, which will be really, really amazing. Only New Mexico and Idaho psychologists are lined up to do that. So right now, we're sitting in the state, we have 8 prescribing psychologists in the state. That might not seem like a lot, but when you look at the total number of psychiatrists that we have in the state, that's adding a good chunk of folks that are highly, highly trained. And I would anticipate that number goes up pretty quickly. So by 2024, I think we'll be over a dozen. And then Idaho is pretty permissive in terms of like access to licensure. So Governor Little here, he has an executive order for universal licensure. So prescribing psychologists in other states could come to Idaho and get licensed here. So really the door is open. And it's open, like you said, because we need help here. So we have a shortage of prescribers. So what I do, I work in an integrated mental health clinic, and I work very closely with a psychiatric pharmacist, Lucy Wilkening. And in Idaho, pharmacists also have a broad scope of practice. So our psychiatric pharmacist really manages the medication, and I work more as a traditional psychologist, but it's just having that education and training is the interface. It allows you to talk about it. But we have students that are now working at St. Alphonsus in the pain and spine clinic. That's Paige Haviland. This training just really changes. Again, it changes you as a psychologist. And I think it's perfect training to get you prepped to work in an interdisciplinary or integrated setting with other providers.
Absolutely. And I think, definitely what you talk about in terms of dedicated training and that gap between who has the area focus and who prescribes most of the medications. I mean, it makes me think, not I hope I don't get in trouble telling this story, but not to pick on my husband, but he's a primary care provider. And I remember in residency, him being on like his mental health rotation. And he came home that afternoon and he was like, gosh, this is just like the easiest rotation. I was like, what'd you do? And he was like, oh, we just sat around and talked about like how Otis Redding songs are all about depression. And I was like, weren't you supposed to be like talking about patient management and stuff like that? But, it kind of points to family medicine providers are really have the super broad scope and are being asked to do everything. And that bleeds over into doing medication management, particularly for mental health conditions. And it's with pretty limited training when it's held up against, clinical psychologists, social workers and others, psychiatric pharmacists. But despite that, they're the ones that are controlling so much of the prescribing and medications.
Yeah, it's 80 to 90% of psychiatric medications. I mean, it's a vast majority. To follow up your story, sometimes I make a slightly inappropriate example with gynecologists. I mean, women see their gynecologists every year. And a lot of gynecologists manage psychiatric medications, which is great. Like, I'm not knocking them. We need folks that have that training across the board, but it's when you get in the weeds, it's that specialized training. I teach at Idaho College of Osteopathic Medicine in their mental health module, and they don't get a lot. I mean, they get enough, but really, when you get out of medical school, medical students have basically the same training, like wherever they went to medical school, but then they specialize in residency. Like your husband, that example, that's where we expect them to get extra training. Now, in contrast, you've got a psychologist. So our students already have doctoral degrees, right? So they have a PhD or a PsyD. So they're looking at between 5 and 7 years, maybe a little more, of graduate school. And that's after their undergraduate degree. And so they get done with that, and then they have to do this postdoc training. And so our program is an additional 2 years of coursework. So it's very, very rigorous. Now, just like that Department of Defense psychologist, where they're just taking a regular old psychologist, we really follow like the same model. Some programs do have pretty intense prerequisites. We don't. We want to take just a good old psychologist and figure out how to specialize their training. So the first year of the program, we go back and it's really basic sciences. So they do like anatomy and physiology. And they're in the anatomy and physiology labs, the same labs that the medical students use. I mean, they're shoulder to shoulder in that lab, and they have some of the same instructors. Pathophysiology, so cellular and molecular neuroscience, courses like that. And then in the second semester, they learn like the basics of physical assessment. And then they start to learn about pharmacology, in general. And then we do some training in the summer. We do clinical training for some students. So that's in physical assessment. And then that kind of unlocks the second year of the curriculum. And that's where you get into the specialized coursework in psychopharmacotherapeutics. It's kind of a mouthful, but that's why they're there. So that's a 9-credit course sequence. Like at ISU, we have a doctoral nurse practitioner program for psychiatric mental health. We kind of looked at potentially sharing those courses, but those folks would only get 3 credit hours in psychopharmacotherapeutics. I mean, our students would have 9. So we go above and beyond that of just about anybody. And I think the didactic coursework is important, kind of in contrast to the training that you might get on a residency. I think that gives us a lot of control over the material. And the American Psychological Association, it's not called accreditation, it's called designation, but they oversee programs in their curriculum to ensure that it's of the highest quality. So our students get done with that, all their coursework, then they do an additional 400 hours of clinical supervision, and then they would have to pass a national licensure exam. It's called the PEP exam. So the psychopharmacology exam for psychologists, it is a doozy. I mean, it's the hardest test I've ever taken. Sometimes I bite my tongue a little bit when my current students ask about it, but they need to know. I mean, this is extremely rigorous. So that's a national exam that's administered by the Association of State and Provincial Boards of Psychology. It's incredibly hard, and it has a wide range of content areas. So when you look at that exam plus the exam for professional practice in psychology, that's the EPPP that most states you need for licensure. Psychologists have been through a lot. So by the time they're getting ready to prescribe, I mean, that is, it could be 10 years of work after their bachelor's degree. So, I mean, like 14 years of college. They are just way over prepared. But they still have a lot to learn.
Makes me tired just thinking about it. But no, I think, again, not to knock any other discipline, but just thinking about this more as like a care team approach, that you have folks like family practice providers or gynecologists that are managing a lot of the patient population, but then thinking about prescribing psychologists as having this true expertise. So when you think about your graduates fitting into systems of care, like really what are some of the benefits and the roles that you see them playing within those care teams or larger care systems?
Yeah. So our student Paige Haviland, she is the first psychologist in Idaho to be credentialed within a hospital system. So she is working side by side with a psychiatrist who does supervise her. So our prescribing psychologist will come out at a provisional level at first, and that requires a supervision. So they'll at minimum have 1 hour a week of supervision, but they're working hand in hand. Additionally, just kind of the way that the laws and rules are set up in Idaho is that a prescribing psychologist would work directly with the patient's primary care provider. So that's like the major link right there, is just with their primary care provider. So even if they're not in an integrated setting, they are communicating actively when they are working with a patient with the primary care provider. In an integrated setting, I like to think about it really just kind of super practically. Like I haven't been to my primary care physician and had them go like, hey, we should go walk down the hall and go see Dr. So-and-so about this particular issue. And, like when you look at the research, and the numbers are kind of a little all over the place, but like 30 to 40% of visits to primary care providers are for psychological issues, right? And a lot of the things that are impacting folks' health negatively is related to like lifestyle, right? And so we need behavior change. And the last time I checked, like behavior change was a psychologist game, right? And so even if it's not writing a prescription, it's just having that link that you can go see the psychologist down the hall. Additionally, if somebody has psychological issues, a primary care provider doesn't have the time to adequately address those concerns. They're seeing people quickly. It's, churn and burn. So to have the ability to take someone down the hall to a psychologist that does have that appropriate medical training as well, that could spend an hour plus with a patient is an unbelievable asset. So I think it unburdens medical providers. And right now, as things kind of shake out in the state, I think that Idaho will develop its own kind of unique identity in how prescribing psychologists are practicing. And although there's 8, those 8 are pretty fresh in the state. So it really hasn't been well defined yet, but it'll be interesting to see. And I hope that our medical colleagues, recognize the benefit that a prescribing psychologist could add to their practice. And if they want to improve outcomes, I think we're a critical addition to that healthcare team.
That's definitely paints a clear picture in terms of the care team. And you talk about perception kind of on the medical side. Has there been pushback against this prescribing psychologist role in the state or across the country?
Yes. Yeah, without a doubt. And it pains me that there is such pushback. Frankly, I wasn't fully anticipating that as I stepped into this role. There is. There on a national level, there are a few organizations that are opposed, and some psychologists within the field are opposed to prescribing psychology. But the American Psychological Association has acknowledged that this is something that we should pursue, and that they did that long ago. We're 20 years out. So even though there is opposition on a national level, it's still moving forward, and you have to overcome some of that opposition. A good example would be like in the VA. So when we're talking about the origins of prescribing psychology, the military, those rural areas in the military. So we're good enough for folks when they're enlisted, but in the VA system, total no-go. So no prescribing psychologists. And it's, that's really, for me, it's just kind of disheartening. And folks are actively working to change that because they recognize the value that prescribing psychologists can add to that healthcare team. And then within, each state, as they have these legislative efforts, you do sometimes get pushback from the medical community. And certainly when this happened in Idaho, a lot of it was before my time here, but there would be negotiated meetings with the Idaho Medical Association and the Idaho Psychiatric Association. Now that we're here, though, the opposition seems to be slightly waning a little bit, but there are definitely specific hospital systems that have said flat out no. In contrast, others have embraced this idea, like St. Alphonsus, and I'm so appreciative of that. My best answer to the solution of this is just give it some time. Our folks that are coming out of our program are so well trained that as they start practicing, they will open the doors for other prescribing psychologists. And I wish I had like a fast forward button on that, but it does take time. And having all of this occur kind of in the midst of the COVID pandemic makes it that much more complicated. But hopefully we're on the way out of that.
Yeah, I think makes everything a bit more complicated, certainly. But, it seems like part of some pushback could potentially be around a different philosophy around medication. You kind of alluded to the fact that clinical psychopharmacology thinks about and utilizes not only adding medication, but subtracting medication to manage conditions. Can you talk about that strategy and how it might be in contrast to some other training that other disciplines might have and utilize?
This is a broad generalization, and I know it's not exactly true. But what a psychiatrist does is manage medication, right? And that is incredibly important. That is their tool that they have. There are other things, I know that. I'm just making this simplistic. But a psychologist is trained in lots of different things, right? And what at the end of the day, what I want to see happen is that we're using empirical evidence to guide treatment decisions. So when is the best time to use medication? When's the best time to use therapy? When's the best time to use them both in combination? What are our patient preferences? Also, things like that. So psychologists have multiple tools in the toolkit that they can use, and that unprescribing for a prescribing psychologist, I cannot stress how important that is. Polypharmacy is a huge problem. It's a really big deal. I mean, my clinical practice, I work with a lot of folks with developmental disabilities and brain injuries. And the amount of inappropriate medication that comes through my office is just shocking, staggering. So duplicate medications, two medications that are supposed to do the same thing. There's no evidence that works. Again, polypharmacy. Somebody might be on 5 or 6 psychotropic medications. And all medications have side effects. I mean, there's just no way around it. At the end of the day, right now, we don't have any medications that cure any psychiatric disorders. Not one. Which is kind of wild if you think about it. Like all our medications just suppress symptoms. And maybe someday, and that someday might be a lot closer than we might think, there could be medications that could cure something like post-traumatic stress disorder, maybe even depression. I mean, there's a lot of hope in like the field of the psychedelic medicine right now. It's kind of a buzz topic, no pun intended. But other medications like, ketamine, maybe we will have a cure for some psychiatric disorder in the near future. But for right now, we just don't. So I don't know which phrase I like, but deprescribe or unprescribe or remove inappropriate medications, I think is absolutely critically important. And there's nobody better than a prescribing psychologist to do that, because we can implement some of those therapeutic strategies that somebody might need at that point to help manage something like anxiety.
So can you maybe walk me through like a patient with a specific condition and how prescribing psychologists might serve that person, just to give us a sense of, what does care actually look like when you're working with a prescribing psychologist?
Yeah. So, I'll use myself as an example. And again, I'm not exactly a prescribing psychologist, so I would be consulting, but I'll make the link for you. This would be like a referral comes in, and it's a graduate student that has new onset ADHD. So they're in a professional program. This is a pretty heavy hitter student, and the first thing that kind of raises an eyebrow is new onset ADHD. But they come to see me, and in my practice, I do mostly assessment and testing. So for this individual, really quickly in doing like a clinical history, it didn't seem like ADHD was the correct diagnosis, but it did seem like anxiety was a pretty major issue, and depression. So we did just some very quick assessment for ADHD, anxiety, depression. At that point, we'd make a diagnosis, and I'm kind of changing things for this particular person I'm thinking about. And honestly, I can't remember what the diagnosis was. It doesn't really matter. But we didn't diagnose ADHD, and that's the important part. It was like something like major depressive disorder with anxious distress or something like that. And so I then thought, what I do is I get a very thorough history. We get medical history to make sure that there's no medical comorbidities that are causing the problem, like like a thyroid disorder or something like that. Get a family history, ask if there's any family members that have similar conditions. If they do, what medication worked for them. And then I think a lot about side effect profiles of medication, because sometimes we can use those side effects to our advantage. Like if maybe a medication that's slightly sedating might be a good thing if somebody needs help with like sleep or something like that. So then, but I do consult with my psychiatric pharmacist, and then she ultimately would write and manage the prescription. Sometimes medications don't go as planned. This individual developed like a rare rash in response to medication. We're trained to identify that. I mean, we spend a lot of time going over potential side effects, adverse effects of medication. So that person, we thought we had the right medication. We were pretty excited about that. It was working, but they developed this rash. So we had to discontinue the medication, switch to a different medication. And that example of like, okay, we did a good differential diagnosis. Our treatment plan didn't go as anticipated. We had an adverse event. How do we respond to that and get this person a medication that they're not going to have an adverse response to? And so it would be kind of similar to that. So we're spending quite a bit more time with folks. If you went to see a psychiatrist, your first appointment, in some cases it could be 15 minutes. And then your medication management visits would be very short, but we would be spending sometimes several hours for the first appointment and then like 50 minutes for the follow-up appointment. So it's different, but in the end, it's kind of like seeing a psychologist. And I know a lot of folks are kind of hesitant to see a psychologist, but usually we're pretty nice folks, and we're there to help. That's the important part.
Well, that's perfect, and I think that that's a great place to end. Is we're nice folks and we're there to help. That's that's a good way to, I think, summarize really in terms of the discipline, the orientation, and the training that you've described, and really how it's working in Idaho. So I just want to say thank you so much for your time. Thank you for the work that you're doing, and hopefully we get to have some more conversations with you in the future. About what's happening in your world and the world of this emerging discipline in Idaho. So thank you.
Oh yeah. Thank you, Rachel. I appreciate it. I love this stuff. I can talk about it all day. So there are so many potential follow-ups to this. I would love to join you in the future. Thank you.
So that's the end of our conversation with Dr. Eric Silk. We're looking forward to some follow-up conversations with him because we just dove in a little bit today. We've got resources in the show notes, and thank you again for listening. Always remember to like and subscribe wherever you get your podcasts, and just remember to give each other a little life support. Life Support is a podcast developed by CHU, where we talk to providers, experts, and others about their experiences with health and the systems that create it. This podcast's music is written and performed by Anthony Leon. The show is also produced by Anthony. For more information, visit us on the web at chu.org, and remember to follow us on your favorite podcast app. Thanks, everybody.